First, I'd like to thank all the previous speakers because you've basically covered all of my presentation. But some of the stuff that's specific to WA, I'll go into a little bit more detail, which is great. The traditional acknowledgement has been done fantastically. I just also like to say, as a Noongar woman, I feel very welcome in this space, in this area, so thank you very much for your welcome. Okay, a little bit of an overview. I was going to talk about the access to the breast screening, the challenges that we face, some of the background in Aboriginal breast cancer, the screening and diagnosis, and some of our, I call them successful strategies, but there's still a long way to go. No matter how successful, you can always improve on participation and outcomes. So the things that impact on Aboriginal women accessing services, we've talked about the culture, the language, spiritual beliefs. A lot of Aboriginal women don't want to do a mammogram because they don't see the point. Even if they find a breast cancer, they're not going to do anything about it, so why should I? This is, you know, I've got breast cancer so that somebody else in my family doesn't. It's maybe payback for something that they feel they or one of their family members have done. And I initially thought, I've read this in several articles, and I initially thought, well, this may be more true in traditional Aboriginal women. However, just recently I'm doing over a long term, I've been doing my Masters in International Health, and I've been doing focus groups and interviews with Aboriginal women about their own personal beliefs and thoughts about why do you have a mammogram? If so, why? What enabled you to do that? What encouraged you? If you don't have a mammogram, why don't you? You know, what holds you back? I've spoken to health workers and said, you know, why do the women in your area not participate, or why do they? So, and the spiritual beliefs actually came through quite a lot. The individual diversity, you might have two Aboriginal women from the same family in the same area. One will have a mammogram, one will go through treatment if they're diagnosed, and one just doesn't want anything to do with it. Some, even if they're diagnosed, won't go through treatment. And we've touched on this, every other speaker's touched on the perception of the racism. Whether or not the services are racist, it's the perception of the person, of the client. And often people don't think they're racist, and it's a very, what's the word? It's a sneaky sort of racism, because you think that you're not racist, but it's just the paternalism or the maternalism, it's the pat on the shoulder, the people that feel that, and also the past experience. It may be just that person's had a bloody bad day, and so they're taking it out on all of their clients, but because you're Aboriginal, you feel it's because you're Aboriginal. And I speak from experience on this. Some of the other challenges, you know what, that glare is really hurting me. Okay. So the diversity of Aboriginal cultures. Australia-wide, specifically in WA, we have something like 100 language groups. We've got so many different clan areas, skin groups. I'm a Noongar woman, but I have family in the Polku people up in the Pilbara. I married a man from Jigalong who's also got affiliations with the Yamaji people in the Midwest. So, you know, just amongst all those cultures, we all have slightly different beliefs and cultural practices. The languages, I've said, we've got about 101 different language groups. That's not mentioning the going into dialects, some of which there may only be a handful of speakers. We have a high staff turnover. You know, Aboriginal people they set a great deal of store by having relationships with the people that they see, especially in remote and rural communities. They'll get comfortable with one health worker or health professional, then that person leaves. You're not always going to get somebody who is as passionate or as connected to the community. Also, when new staff begin in a new position, they bring their own sets of ideas and their own ways of working. I've worked with Breast Screen for 9 years now, and in that time I've seen a lot of staff movement, especially in some of the remote areas, which isn't necessarily an easy place to work. But I've had fantastic relationships with some key staff people who get the Aboriginal women in from remote communities. Unfortunately, if one of these staff members leave, it's very hard to get a relationship with other people. In one particular area, we had fantastic participation, 68% up to some of the areas, which is great considering the national target is 70%. And then this staff member left, Another lady came on board, and as I do, I contacted them before we went to this area, and I said, great to have you on board. This is some of the things that we've done in the past. And she said, that won't work here. I said, well, it's actually worked in the past. Your predecessor's done fantastic things getting the women in. No, it's not going to work here. I'm going to do this. And of course, unfortunately, that participation in that year dropped down to about 40%. So it's a big difference, and it's a key indicator that we really need passionate, open-minded staff in the areas. The lack of understanding of the screening program. A lot of women have said to me, I'm feeling fine, I don't need to have a mammogram. They don't understand that it's for well women. Others think that maybe the mammogram will cause the breast cancer. Having the mammogram and squashing it, you're going to break those cells and it's going to cause breast cancer. Also the fact that screening, they don't realise that it's to find breast cancer early rather than preventing it. Some women have said to me, I've had a mammogram 6 years ago, I'm right, that's fixed me up. And these aren't all traditional remote community women. Some of them are in the city and urban areas. Trying to screen around law times. So if there's sorry business, roads in the communities are often closed, so women can't travel over them. If it's man's business, women aren't allowed to travel at the same time as the men are. So if we are unlucky enough to have our screening van in that area, we're going to have a low participation. Often the same as if somebody's passed away, we'll have a low participation. As much as we try, and in most of the areas we've really succeeded, I think, of course there's more work to do, but making it women's business, and it's women's law business. It's looking after yourself so that you can look after everything else, your family, your culture, your land, your country. And we've touched very in depth, I think, on comorbidities. But also a lot of Aboriginal women are carers for their family, for their grandchildren, for their parents, for extended families. So, if you've got a sick child, you're not going to come and have a mammogram. You'll put it off and put it off and put it off. I think that's pretty much the same with all women, not specific. Some of the screens of the remote communities is the distance between towns. Specifically in WA, I'm the only Aboriginal program officer with breast screen in WA. So I cover an enormous area. Breast Screen WA may be slightly different to some of the other breast screens around Australia in that we have the one service that covers the whole state. So when we leave Newman, say Newman's in the middle of WA, when we leave Newman, our next stop is 1,000 kilometres away in Broome. So if you've missed out in Newman, you either wait till we come back down into Headland, which is about 3 months later, or you go to Tom Price, which is 5 months later. So it's the distance between towns is extreme. The isolation, it's not only isolation in distance-wise, but isolation from services. So straight away there's an access issue there. When we go to the remote areas, our equipment can't go off onto the gravel, and we've got some really bad, Northern Territory and Queensland would probably understand, maybe the top of South Australia would understand the same sort of issues with the gravel roads, and sometimes it's just a creek bed that you're crossing. Sometimes it's not even a proper road. So that isolation is getting the women in. When we go to Laverton, we bring women in from Managera lands. Some of them travel 800 k's just to come for their screening, and that's only one way. So, when we talk isolation, we really are talking extreme isolation, and it's not just distance. The difficulties in recall for further views. It's great if the women are in that area, but if they've come 800 k's and they've gone back out, how are we going to get them back in? Often when they go to places like Laverton, they may be closer to Alice Springs to come back for further views there. So there's lots of difficulties in that, and also for the follow-up. Breast Screen WA find it really hard to meet our national accreditation standard of screening of the lady going to assessment after the screening if you need to. So that's 28 days. Sometimes it takes 28 days just to contact the health service provider. They all need to come to Perth. Well, the majority need to come to Perth for assessment. Occasionally they can go to Geraldton or Albany. And I think those are the only places, maybe Kalgoorlie. And there's little support for women in Perth or in the cities. Some of these women are coming to Perth for the first time, coming to the major cities for the first time. So It's a completely strange environment. They don't know how to catch a cab. They don't know where to go. You know, the taxi driver might be taking them on a big loop and they won't know. They're so out of their comfort zone. Okay. So why do we need to encourage breast screening and awareness? We've already talked about the early detection leading to better outcomes, and the breast cancer screening, since it's been introduced, it's reduced the mortality of breast cancer by 21 to 28%. We've already spoken about all of this, so I think I'll just skip through it. I was actually amazed when I'm listening to all the other speakers about how common, how similar it is in WA to the rest of the country. I always feel that we're sort of a little bit almost another country. So in WA, our screening rate is a little bit better than the main, than the rest of the country, it seems. Our participation rate for Aboriginal women is 44%. However, the urban areas are only running at about 33%, so that's a lot less. They're more likely to have symptoms, less likely to have rescreens, not assessed within the 28 days, more likely to live in outer regional or remote areas. When they're diagnosed, we've spoken about them having the larger tumours, the lower 5-year survival, the higher risk of dying from breast cancer. See, you guys are fantastic. You've done all my presentation for me. It means I can keep on time. WA participation rates, they've increased. We had a bit of a dip in when we started the 2011 ABS stats because the more Aboriginal women were identifying. However, we seem to have recovered from that quite nicely. So how does breast screen do some of their things? I'm the Aboriginal Program Officer. I specifically deal with Aboriginal women. We've got an Aboriginal Women's Reference Group which is made up from Aboriginal women from around the state. Everything that we do goes through them and they take it into their communities. So we do get genuine feedback from community women about our program, about our strategies and about our resources. Our Aboriginal health professionals are absolutely invaluable all around the state. We've just developed a new breast cancer awareness flip chart, which I've got over there if anybody's interested in having a look at it, which I go out and provide training to. I learnt from the bowel cancer screening flip chart, you actually have to get out into the community and explain to the women how to use this and what it means and give them that ongoing support and the background information. You can't just plonk this flip chart, fantastic as it may be, in a community and say, this is how you just use this. We've got our new vans. We visit over 100 towns every 2 years. We have 10 fixed clinics in WA. Oh, we've got so much. We provide transport in buses and we fly women in from remote communities. We provide accommodation assistance. We work with other women's health services in the area and we link with Aboriginal community agencies, and we do. We encourage survivors to be visible in the community. We do a lot of community health and education programs. I do a picnic in the park. I invite women every October to come along and have a picnic in the park. We have guest speakers of survival, women that have survived for 5 years, women that have just been diagnosed, how they feel, women that have been survivors for 20 years. So, we get them out there to say, yes, it is a terrible disease. Yes, we're getting it more, but we're also surviving more. Okay. I think we've covered all of those things. But basically, we do need to improve the access and acceptability of health services to Aboriginal women. A lot of people don't believe that they're doing anything openly racist, but just some of the it's not even paternal, it's the patronising sometimes. And I'll just leave you with that final thought from Dr. Fiona Stanley, is that people don't start out to be racist, but often just in their behaviour they are.